Right, now, very quickly I'd like to show you sciatica. You know, this is a straight leg raiser, and that's going to traction the nerve root. Now, when you do a straight leg raiser, you really should have your hand on the knee because that will allow it not to buckle, make it a straight leg raiser. So there's good credit for this. When you do that, that's going to traction that, right? Nerve traction, radiculopathy. But we said sciatic kind of originates from about here, and radiculopathy would originate right from the center, right? Right from IVF or canal stenosis or whatever. So pretty close places of origin and then radiating down the leg. Now usually sciatica doesn't go too far below the knee, gets into the posterior calf, but usually not to your foot. So usually if it goes all the way to your foot, we're thinking radiculopathy. But let's say there's just some pretty good burning going on, it's just starting, you're a little confused. So let me ask you this. What would someone say? I just want you looking at this angle for a second. If they said ow right here and it was L5 radiculopathy, what would they say if I just kind of brought it this way? Ow, right? How about out here? Ow, because we're still tractioning that same amount of angle. Everybody agree? Okay, now I want you to pretend you're the piriformis. Okay, so this is your moment. Be the piriformis. Okay, so you live right here, and your job is to contract and just chew on that sciatic nerve. Got it? Okay. All right, so what do you... Ow! Right, you got it? Okay, now what are you going to do, piriformis, when I do this? When I come across the body, internally rotate and add to... I gotcha! So we just made it worse. Now what are you going to say when I do this? Because you relax, piriformis. Okay, so ow. See, what would radiculopathy do? So we have two ortho tests, one called Bonet's, one called Soto, which clarify for us and kind of clean up whether or not we have a radiculopathy or a sciatic neuropathy. Now we'll talk about those more on the ortho page, but you can see now why radiculopathy and neuropathy when it comes to brachial plexus and sciatica can be a little confusing. Alright, now we're on page 58 and you're either totally confused or some things are getting cleaned up in your life. Okay, so we've talked then about the fact that typically when we move extremities around and aren't moving the spine, we pretty much know it's trapped in the periphery. But we've got two little culprits that can get trapped, even though they're peripheral nerves, and be aggravated by some spinal mechanics. So we've talked through the fact that you've got to have some finesse to differentiate brachial plexus and sciatic. Now, mostly when we're talking about, carpal tunnel and tarsal tunnel, it's going to be burning and it's going to stick mostly to the hands or your feet or wherever the site of entrapment and just distal to that. Now, there are muscles that can cause entrapment of these. So we're going to talk about the fact that muscles can cause it, but muscles are also affected by them. So if you have carpal tunnel, it might be from the pronate, or if you have the median nerve that's entrapped and it's not in the carpal tunnel, it might be the pronator teres that has spasm and causing all of these things to go weak. So there can be a spasm causing the peripheral neuropathy, but that is going to cause weakness or paresis of several muscles that have to be strengthened. So it's going to affect the muscles in a compartment. We're going to check those multiple muscles. And it can also cause a little burning in a localized area, so that the name for that, the clinical name, is a pure patch. Rather than calling it a dermatome, it's a pure patch. Now, when it comes to what ortho, I mean, you can't say Bonet's, which is a lower extremity, for carpal tunnel, and so they're very unique and they vary quite a bit, so we'll go through those on ortho day. But we do have to get this down, that it is an NCV, an EMG, and SSEP. So this is the first time we've said the word NCV, nerve conduction velocity. So nerve conduction velocity is not used for myelopathy or radiculopathy. It is used to confirm that you have a neuropathy. Now if it's a close call, it might distinguish radiculopathy from neuropathy. See these up here? Okay, so it can be used to confirm a neuropathy from a radiculopathy, a suspected radiculopathy. But it is typically used for a neuropathy. That is the right time to say it. So NCVs are when we put two pins in you and we see how fast the charge goes. Now you wouldn't want us to stick two pins on either side of your IVF. Right? So they are done in the periphery for peripheral nerves, but they will rule out or rule in radiculopathy. So that's how that kind of gets a little dicey there. But if you're going to keep this case, realize then you're probably going to use B6. Remember pyridoxine, your P vitamin? Well, your P vitamin, pyridoxine, is really good for peripheral nervous system, but it's also a great diuretic. So it has just a natural diuretic in it, and a lot of times the reason people get a lot of peripheral neuropathies in their hands and feet is when they're swollen. So hypothyroid, pregnancy, that kind of thing, but they're not going to just get it in one hand. They'll get it in both hands, both feet. You know, it's usually a systemic event when that usually is a benefit. And of course, physical therapy would be on the top of your list to take care of some of the target tissues and structures causing the entrapment. Now, as Dr. Laura kind of slides this up, we're going to take a look then. One of the things I want you then to think in your mind's eye is, where can you have the signs and symptoms of myelopathy, radiculopathy, and neuropathy? Now let's be honest, because the answer is the whole body. So you can't tell them apart by symptoms, okay, until you get really good at it and say, well, it's when you flex your neck, or it's when you rotate just to one side, or it's isolated to this part of the body. So that's why you have to be very clever at that box up there, and then you realize, well, the problem really was in your brain or in your cervical or thoracic. Okay, but if it was lumbar mechanics, then you know it couldn't be myelopathy. It has to be a radiculopathy or at least a sciatic neuropathy. So as you get better at this, then realize myelopathies have to originate from problems either in the brain or cervical or thoracic. When we talk about radiculopathies, you can't have them at C1, C2 because there's no IVF. So starting at about C3 on down, you can have radiculopathy, 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 and it owns the lumbar spine, whether it's canal stenosis or disc lesions or what have you. But once you've left the spine, if you think there's entrapment anywhere out in the body, anywhere, even on your face, that would be neuropathy.